Hi, good evening, everyone. Welcome back to another session of our webinar on a Wednesday by Beating Hearts. And today we have with me my colleague from Sunway Medical Center, who is a Brigadier General. He just retired from the Army. Just retired, right? How come there's sound behind? Okay. And he's also an anesthetist, and you're the president of what? Hyperbaric. Can you tell me more what you are?
I'm also the president for the Asian Hyperbaric and Diving Medical Association.
And you've been the president for how long now?
Yeah, so this association, AHDMA, had been established about 19 years ago from countries around ASEAN and Asian region.
And you came back from Koh Samui for the AGM, right?
Yes, so yearly we try to have our annual scientific meeting in various places. So this year was in Koh Samui, Thailand. Over the last 4 days, we had a big conference on marine envenomation, on monoplace chambers, and also 2 days of a main conference. Last year was in Kota Kinabalu, quite well attended, 100 over people. This year, not too bad, about 80 participants.
So these are all doctors, or they are all anyone?
Mainly doctors who are interested in diving and hyperbaric medicine, but also a mixture of non-doctors like hyperbaric nurses, paramedics, dive technicians.
So basically for healthcare people.
Yes, healthcare people related with the diving and hyperbaric world.
I see. Okay, we start with your talk now.
All right. Thank you for inviting me. So I'm just going to share screen.
Okay, good.
All right. So thank you once again for inviting me to give a small talk on diving medicine, a topic that is not really well known because it's not usually taught in our regular medical curriculum. So usually people that are involved are from the military background or people who are divers and then somehow got themselves into diving medicine. So quite a big outline, but I'm just going to hopefully keep it concise, and do stop me anytime you have any questions. Briefly, I graduated in 2001 from UM, and I was commissioned as a captain in the Malaysian Armed Forces, and they have sent me to the medical officer underwater medicine course in Sydney when I was first year MO. And since then, I've been a diving medical officer. And subsequently, I become an anaesthetist and further my study in UM and Australia. And that's also where I further my sub-specialization in diving and hyperbaric medicine. So I was, my last appointment is as the head of diving and hyperbaric medicine in the Malaysian Armed Forces, and I'm retiring soon. So yeah, with that, just a quick history on diving. So the interesting thing is that we have always loved the sea, as humans. We're always curious, and whether for food, for economy. And we can see that even in old stone carving thousands of years ago, soldiers were using inflatable bag made of goat skin tied to their belt, trying to breathe underwater to attack the enemy. And of course, without any equipment, back in those days, breath hold diving is how we swim even until now. So we have our bajau. They can hold their breath up to 5 minutes. And we also have the famous ama, or woman of the sea, Haini, in Japan. And they have been romanticized because the interesting thing about them is that back in those days, they dive in cold water fully naked.
Oh.
Yeah.
Oh.
Now they cover up. So, but of course, with breath hold diving, your time is limited underwater. So you try to use various things like snorkel, but there is a depth limitation due to the physics of it. You can't have a super long snorkel and try to go down 20 meters. You can't. The pressure of the water will crush your, will be pressing against your chest. So there's no way you can generate enough negative pressure to take in any breath. Then people try other things like diving bells. Alexander the Great, try to explore underwater. But of course, I think he's going to get a lot of headache because of hypercarbia inside that small space. And with the industrialization, diving technology improved, and you can see more advanced dive bell, various different contraptions. And then further advances in the 1800s, you have this dive helmet, which allow men to go deeper and deeper underwater. And as they go deeper, they will find they actually discover new problems, new signs and symptoms. And at the same time, also, they were building bridges. And to build this bridge, you need this thing called a caisson, where there is pressurized air to keep the water out so that the worker can do their work. And they noticed that a lot of these workers, after the work, they come out, they get painful joints, and they walk in a bend position, which looks like the Grecian band, very popular that time. Pretty woman, it's fashionable to walk with, with that kind of band. So when they see their colleagues like that, they go, oh, you have the band. So that's why nowadays decompression sickness is still called the bands. And they notice that if they go back to work or dive the next day, their symptoms improve. So there's some sort of early history about decompression sickness. Of course, at the time they didn't know what is decompression sickness. And it was only after the World War II, where diving became really the domain of everybody, and was actually popularized by this French Navy captain, Cousteau, who invented the aqualung, which becomes what we know today as scuba. And nowadays it's also modern with so many different equipments that you have to master to actually dive. Yeah. So coming to types of diving, we have, of course, again, breath hold diving, which is nowadays a professional sport. And you can see back in 2022, the depth that we had never thought possible. The world record is now held of 301 meters. That's crazy deep. And they can hold breath 11.5 minutes. I can't even hold more than 2 minutes of breath. So that's a professional record.
I have a fear. I was thinking of trying to overcome my fear by doing free diving, but I'm still fearful of even
You need special training on how to overcome the psychological effect of hypoxia, and then how to overcome all this hypercarbia, so that you just have to take a breath, but yeah, that's a record. And the other type of diving, which is most popular or most familiar with everybody, is scuba. And do you know that scuba is actually a acronym for self-contained underwater breathing apparatus, SCUBA. And it's now being used everywhere, recreationally, commercially, scientific, in the military. And it really opened up since after the World War. Cousteau have popularized aqualung. People can use it because you've got freedom of movement, does not require any team support. But the disadvantage that you're limited to 40 meters because of nitrogen necrosis. And of course, there's limited gas supply depending on how much or how many tanks you can bring. Still very common is a surface supplied breathing apparatus, SSBA, like the whole diving helmet that I showed just now. Mainly used in commercial and military, where they go really deep, where you need mixed gas. And with this mixed gas, you're able to do deep diving, and there is communication, monitoring. But being tethered with all this umbilical, you can't move much. But basically, all they do is they go down to the depth that they want, they do their work, and they get back up. And the other type of diving is rebreather, we call it, closed circuit, with 100% oxygen and carbon dioxide scrubber. So it's pretty lightweight and a very small tank, only small oxygen supply is needed. It's used by the military, to have stealth, so that when they attack, nobody knows there's bubble, there's nobody coming, the commandos are coming from underwater, or when they disarm explosive underwater. But nowadays it's becoming popular among photography, underwater photographers, because without bubbles you can get really close to the marine life. But it's limited to depth of 7 to 8 meters because of the pure oxygen. And there's always a risk of technical failure. In fact, nowadays, we often hear of people having trouble drowning because of using these new devices.
Yes.
And finally, we have the saturation diving, which is a really deep diving. They stay underwater for 3 to 4 weeks at once and to do their job, very complex operations. So with that background, I would like to dive into the diving diseases or condition. There are quite a number of things that us as diving doctors cover. Is usually a 2 weeks course which covers all these topics. But tonight, I'm just going to focus a bit more on decompression sickness, cerebral arterial gas embolism, and barotrauma. Before you can know or learn more about diving medicine, you need to go back to the basics of physics and some gas law. So just bear with me. Pressure, as everybody knows, is force over area. And we now at the sea level, we are surrounded by the atmosphere, which is 1 ATA or 1 atmosphere. The deeper you go, there is then this column of water around you. Besides the pressure from the atmosphere, there is also pressure of the column of water surrounding you. So for every 10 meters of depth that you go, the pressure increases by 1 more atmosphere. So 10 meters, it becomes 2 atmosphere, 20 meters, 3 atmosphere, and so on and so forth. Conversely, if you fly or go to outer space, then pressure drops because of reduction in the number of gas molecule in the atmosphere. Air becomes thinner. One of the most important gas law that we need to know in diving medicine is actually Boyle's law. Boyle's law states that pressure and volume are inversely proportional, meaning that when pressure goes up, volume comes down and vice versa. The other important gas law in diving is Henry's law. And this law is pretty simple actually, states that when the partial pressure of a gas over a liquid increases, then the proportion or the amount of gas that becomes dilute in the liquid increases as well. So keep in mind these two gas laws because it becomes important in the following diving conditions that we are going to discuss. Firstly, I would like to discuss about decompression sickness. And basically, this is bubble trouble. Proper definition is a medical condition caused by dissolved inert gas, usually nitrogen, emerging from solution as bubbles inside our body during decompression. The key word here is decompression. So you need to decompress first. You can't have decompression sickness when you're on the surface, not doing anything. So there are two possibilities where you can decompress. One is, of course, underwater diver when we return to the surface after diving. And also, do you know, aviators, pilots, astronauts, they also are at risk of decompression sickness. But the difference is that they get decompression sickness at the beginning of their flight, whereas for divers, they get decompression sickness at the end of their dive. So as they ascend to altitude, we are all at sea level saturated with nitrogen. But if you shoot up to the atmosphere really, really fast, you actually bubble up and you can get decompression sickness. So the most important law for decompression sickness is actually Henry's law. So based on decompression theory, what happens is that when a diver descends underwater, pressure increases like we mentioned just now, right? Every 10 meters of depth, seawater, pressure increases by 1 atmosphere. So the deeper you go, the pressure increases, which means, according to Henry's law, your partial pressure of nitrogen is now higher compared to what is inside your body. What you breathe is now higher than what is inside your body. And then in-gassing occurs. That means more and more nitrogen get dissolved into your body. And if you stay long enough, eventually you get saturated. That's the saturation diving that I mentioned. But otherwise, you end your dive and there will be different partial pressure of nitrogen in various parts of your body. And you surface. If you follow it properly, you ascend properly, then most of the time, no problem. But if you ascend too fast, for example, then you create a great pressure difference. And if it's this too great over a certain limit, you have supersaturation occurring, whereby the partial pressure of nitrogen in your body tissue far exceed what is safe limit and can't be blown out from your lungs to the atmosphere fast enough. And all this nitrogen become bubbles in your body. So it's basically like a Coca-Cola. You shake it, you open the top, the can or the bottle, and it bubbles up. So the same thing is happening inside your body. So if you understand that decompression theory, then you probably would be pretty clear what are the risk factors for decompression sickness in divers. The three main factors that can cause or rather increase your risk of having decompression sickness is depth, duration, and ascent rate. So the deeper you dive, which means more nitrogen is going to get dissolved, or you dive very long, then more nitrogen will have time to dissolve in your body. And if you ascend rapidly without following the proper dive tables, then your chances of getting a DCS is going to increase multiple fold. The other risk, of course, will be things like multiple dives a day, repetitive dive, reverse dive profile. What this means is that a good diving practice is actually to do your first dive, deepest dive first. So if you're going out for a dive trip and you have 3 dives, is a good dive practice to dive your deepest dive on the first dive, shallower on the second dive, and even shallower on the third dive. If you do it in the reverse way and you start shallower and get deeper and deeper, you are just increasing your nitrogen load, which means you're increasing your decompression stress. And of course, altitude exposure is important. You are not supposed to fly immediately or climb the mountain after diving, because the reduction in atmospheric pressure will cause you to have risks of bubble formation. There are other predisposing factors, but I wouldn't have time to discuss it in detail. We do that in our course. Things like exercise is quite interesting. You shouldn't be exercising too hard underwater because you're just increasing blood flow and increasing nitrogen load. And you shouldn't also exercise very hard after dive. You're making more bubbles. Yeah. So there are various other factors as well that can increase or reduce your risk of decompression sickness. So we have this, what we call dive tables. For divers, you'll be very familiar, or maybe not. If new divers, they don't use this anymore. But back in the days, we all have to train or learn about this dive table. Basically, people have done research on fit, healthy divers, and they push them to the limit and see how many get decompression sickness. And they come up kind of dive table whereby it will show you like, okay, if you're diving to 10 meters, how long can you stay? And then how long you need to decompress before coming up. This one is the recreational one by Paddy. It will tell you again, if you go to this certain depth. So what you need to do is you use this dive table to plan your dive, and then you dive your plan. But nowadays, people don't use it. Now people all use computer, dive watch. It will tell you very precisely whether you are exceeding your limit or very near your limit, and start going shallower, getting shallower, and then when can you do your next dive and so on. So what happens if you get bubbles in your body? So the effects of bubble can be either direct mechanically or indirect biochemically. Direct means that the bubble can block the vessel, you get hypoxia, or it can disrupt tissues, compress a nerve, strip the endothelium of surfactant. And then indirectly, with all these bubbles going through the blood vessels, it can actually activate inflammation, the coagulation and complement system. So some of this will explain some of the signs and symptoms in decompression sickness. So clinically, how does decompression present? Decompression sickness can only occur upon ascent. Means that once you commence decompression, it can never occur underwater. So if somebody comes to you and say that you start having shortness of breath, pain while still diving underwater, it's pretty unlikely to be decompression sickness. You have to start ascending, and most of the time, 50% of the case develop within an hour of diving. and 90% within 6 hours, which means it's usually early. Somebody coming to you 3 days later was well totally and then suddenly have pain in the joint is very unlikely to be decompression sickness. However, having said that, if there is further decompression, for example, flying too early, going to altitude, climbing the mountain more than 300 meters, then you can actually precipitate decompression sickness. Usually, the earlier the onset, then the more severe it will be. This is data from our Institute of Diving and Hyperbaric Medicine in Lumut, and you can see the wide range of different presentations. Just head to toe, everything can be possible. The most common one is pain, shoulder especially, followed by elbow, and non-specific tiredness or constitutional symptoms. It's really a special kind of tiredness. The diver will come to you and say, I've never felt so tired in my life. And when you treat them in the hyperbaric chamber, they will like oh, it's like suddenly somebody turned on a light bulb. Other things quite common, headache, sometimes skin rashes, a bit of funny feeling sensation here and there, paresthesia. Less commonly and rare will be things like becoming paralyzed, spinal decompression sickness, severe one, loss of consciousness, even death. And this one is interesting one is cutis marmorata, is a skin rash, which is a bit like bruising, and it comes and go, and it's actually a sign of severe decompression sickness and also associated with patent foramen ovale. Similarly, how patent foramen ovale is associated with cryptogenic stroke and also migraines. It's also been shown to be associated with those that have severe decompression sickness.
Okay,
And usually
before,
early sign is
so basically this patent foramen ovale is actually like a small hole in the heart.
correct.
Yes, it's a
So
small.
it's physiological. Most people, 20%, sorry, a lot of the population have PFO, 20%. And being a cardiologist, you'll be quite well aware, we are walking around with it, no issue at all. Most people close at birth, but there's some physiologically still unclosed. And most of the time small, most people die no problem at all. It's only those with very large PFO and those that comes with undeserved decompression sickness, means it dive very shallow, not very long, yet we come up and become paralyzed, then we will be concerned whether you got a hole in the heart.
Oh, okay.
Yeah. So PFO and diving is a huge topic by itself, usually about 30 minutes, 45 minutes lecture on a lot of issues regarding that, because people will be asking, oh, then should I test for PFO before I go diving? It's a very complex issue, which is probably another session we can discuss.
But sometimes from the echo also, we don't pick it up unless we do contrast study.
Right. Need a specific way
So,
of doing. Usually, if I send patient to you or other cardiologists, I will specifically put there, please do PFO echo with bubble study.
Oh, that's right.
Muscle bubble study and also with Valsava.
Yeah.
So then with this a little bit info about decompression sickness, you'll be asking then how do I actually diagnose decompression sickness? Unfortunately, there is no diagnostic test for DCI or decompression sickness. The diagnosis is all purely clinical based on history and examination. We go very detailed into history when a diver comes to us. We want to know what kind of gas you're using, how deep was your dive, how many dive, were there any problem during the dive? Did you do your safety stop? Do you shoot up very fast and so on and so forth? And then the symptoms, when did it start, onset, the progression, what are the symptoms? And usually we can get this from the diver or from his buddy or the dive master. And we also want to know the early management, what was done. If oxygen was given and then the symptoms resolved, oxygen supply finished, habis, suddenly the symptom come back again, then that's quite pointing towards decompression sickness. Or if the symptoms come on after or become severe after they took a flight, then again, this will point more towards decompression sickness. And of course, there are other history that we go through. And we like to draw this kind of dive profile. Okay, start dive at 8 o'clock. How deep was your dive, the deepest depth, and then bottom time, how many minutes, and whether you do a safety stop, and then how long was your surface interval. And again, okay, here, a second dive, he missed his safety stop because he have out of air and then just shoot to the surface, and then symptoms start pretty soon. So this is a very classical kind of decompression sickness case. Others will be, of course, more complex. But this kind of drawing help us to determine, okay, is it exceeded certain limits, any problems, any issue? And you can see here his diving, reverse dive profile. He did a shallower dive first, and then second dive 30 meters. So all these are pointers that increases the risk of decompression sickness. Having got the history, we examine the patient, maybe a little bit of investigation, usually not many investigation. We would then need to treat the patient. If you're in the field, the most important, you need to recognize it so that you can actually start treatment or institute the evacuation. So treatment is divided into initial treatment with oxygen therapy and definitive treatment, which is recompression therapy, or what we call hyperbaric oxygen therapy. So we teach all our diving doctors and diving medical technicians, DMA, diving medical assistant, this one, yeah. Initial treatment, we use the acronym RECOIL, re being rescue. So injured diver need to be out of water, otherwise it's very difficult to give any medical attention. CPR is required, and then O for oxygen. This is the most important, I think. Oxygen, oxygen, oxygen. We advocate you give the highest possible concentration of oxygen for as long as possible. So, for example, if you have only enough supply for 1 hour for 100% oxygen, but the hospital is 3 hours away, don't try to save oxygen and give, 1/3 of it so that you can tahan until the hospital. It's better to give 100% oxygen, finish it in the first hour, and then no more oxygen until you reach your hospital. It is much better to do that than to try to save your oxygen, because you want oxygen to try to reduce the bubble load. And then usually divers with decompression sickness are dehydrated, and when they are dehydrated, the bubbles tend to stay longer. So hydration is good, and we always advocate lying flat. If you place the patient head up, the risk of bubbles will go to the brain, it's increased. And you don't want head down, because as we learn in neuro, head down, you increase the pressure in the brain, yeah? The outcome is worse. So lie flat or a recovery position is the best. Definitive treatment, however, is recompression therapy. So once you diagnose decompression sickness, especially the severe one, you want to get the diver to a chamber as soon as possible. And the reason being that, based on Boyle's law again, increasing in pressure will reduce the bubble size. And with 100% oxygen that we give in recompression therapy, it relieves hypoxia and also help in reducing all this inflammation, secondary bubble effect. So this is the chamber in Lumut Institute of Underwater Medicine in Lumut Naval Base, our largest chamber, 3 compartment. You also have a monoplace chamber where only a single diver or patient can go inside. This is the typical treatment table for decompression sickness, table 6, US Navy table 6. We bring the patient down to 60 feet or 2.8 atmosphere, 18 meters depth, and then they stay there for 60 minutes, with 5 minutes of air breaks to reduce the risk of oxygen toxicity. And then we slowly come up, and then it takes about 4 hours, 45 minutes to complete one treatment. Usually, decompression sickness will need 2, 3, and sometimes up to 5 sessions of recompression therapy to fully resolve the sickness. Chambers in Malaysia, main one in Lumut, pretty busy one here in KL Hospital Tuanku Mizan. We have a smaller chamber, 8+2 men, 2 compartment. We do a lot of clinical hyperbaric. There is also another one in Malacca, but not functioning at the moment because the Camp Terendak Malacca Hospital is being refurbished or rebuilt. But there are chambers elsewhere as well. Commando in Mersing, they have the Navy Pascal, they have in Sempurna, and they're pretty busy treating divers from Pulau Sipadan. There is also another hospital-based chamber in Sepangga, the submarine base. There is a one-man chamber in Hospital USM Kubang Krian, the private one in Penang, private one in KL Jalan Titiwangsa, Sunway Geo, I think in Bangsa South as well. Used to have one in Ipoh, but is now shut down.
Is there one in Sunway Hospital?
No, not in Sunway Hospital, opposite Sunway Hospital, a private one.
Okay, I see.
My ex-army colleague, hyperbaric one, it's a private center, small chamber, 4-man chamber.
Oh, can still put 4 people inside.
Yes.
Oh, okay.
So they are small. They're not hospital based like the one in Lumut, KL, and Sabah. They are hospital based and with all ICU support. Especially in KL, we are able to treat very, very ill divers, intubated patient, multiple inotropes. We can do that. So that's decompression sickness. Hope I'm not running behind time. I would like to just go on to the next important trauma. So baro is pressure and trauma is injury. So barotrauma means injury or damage to the tissue due to changes in ambient pressure. And you need gas and you need change in pressure. So there are few organs in our body which have gas, and those are the ones that we are worried about. And if you may have guessed now, the other law that is important in diving medicine is Boyle's law. And this is important in barotrauma. So again, I repeat, Boyle's law means pressure inverse to volume. When the pressure increases, volume comes down and vice versa. Very important to note that the change in volume is actually greatest at the surface. So if somebody were to come from 40 meters or 30 meters to 20 meters, or you release a balloon, you can see the balloon doesn't expand a lot. But if you release a balloon at say 10 meters to the surface in your lung, if you hold your breath and it's a full vital capacity of your breath, full lung volume, and you hold your breath and you go up to the surface, your lung volume doubles and you can actually rupture your lung. So advice given by non-diving medicine doctors to patients with things like asthma, or they have ear problem, and they say, oh, you want to dive? Can, no problem. You just don't dive so deep. That's wrong advice. In fact, it is the shallow part that is the main problem. And divers would understand this really well. When you want to clear your ears, it's always hardest when it's shallower. So Boyle's law, very important in barotrauma. Various types of barotrauma, you can classify it in ascent, descent, or by organ system. I'll focus a bit more on pulmonary and ear. Those are the more dangerous and common one. So pulmonary barotrauma is the most dangerous of all barotrauma, also known as pulmonary overinflation syndrome or burst lung syndrome. It is caused by breath holding or any problem with air trapping inside your lung, whether abnormality or some disease. And sometimes if the decompression is too great, it's like submarine escape or underwater explosion, it can also happen. But these are the two common ones. So with breath holding, what happens is that you close your glottis, and like what I explained just now in Boyle's law, your lung expand and you can rupture your lung. So the first rule of diving, anybody who were to take up diving, and those that are already diving will remember your dive instructor tell you, first rule of diving, never hold your breath. Always breathe in and out. That is the reason, right? Never hold your breath in diving. So the predisposing factors will be any disorder that can cause gas trapping, obstruction, or any local compliance changes, such as if you have asthma, COPD, any fibrosis of the lung, previous pneumothorax, and so on. And then, especially if you panic. So the usual story is out of air for, still enjoying looking at beautiful corals or mermaids or whatever, and the instinct.
I think my Wi-Fi has problem.
Shoot up to the surface, but that is the wrong way and dangerous way to do things. You should actually blow.
Okay, sorry, we have
All right.
a bit of lagging, huh?
Should I continue?
Yeah, you continue. Can you hear me?
All right.
Okay,
Yes,
can
I
I
can.
ask you, this barrel trauma to the lung is on the way up or any time at all, or on the way down?
Usually on the way up,
On the
because
way
you need
up,
an
right? Because,
expansion
yeah,
of the lung here. Yes,
yes.
usually on the way up. But it's rarely possible as well going down. But most of the time you're breathing, so the lung is just expanding, closing. But of course, if you have a compliant problem, then you can have a rupture as well. But usually it's on the way up, based on Boyle's law. Yeah.
Yeah.
So when pressure reduces, the volume increases. So when your lung overinflate and rupture, a few things can happen. You can have pneumothorax, you can have mediastinal emphysema, and if it tracks into the subcutaneous tissue, you get all this air under your skin around your neck, you can get subcutaneous emphysema. I'm not going to focus on this because I think most of us knows this. I'm just going to focus on arterial gas embolism. So another way is that the lung rupture really alveoli ruptured, one bubble going into the capillaries, and this will go all the way up to your brain, because usually when you panic and you go up, you go head up first. So the bubble tendencies go up to the brain, and all it needs is one bubble to block, and it's like a stroke. You will have hypoxia after that, and you lose consciousness. So it's really serious, life-threatening, and requires immediate treatment. This is the most dangerous and a major cause of death in diving. And usually the symptoms a little bit immediate. Within 5 minutes, 85% of cerebral arterial gas embolism will present. They will lose consciousness, paralyzed, blurred vision, disorientated, with or without symptoms of the other burst lung syndrome. Not uncommonly, the diver may then regain consciousness because it's only one bubble, and the bubble with increase in intracranial pressure will push the bubble through, so they will regain consciousness. But then they will lose consciousness maybe 30 minutes, an hour later, because of the secondary bubble effect. There will be edema, cerebral edema, inflammation, and then they will lose consciousness. So something to be aware of. Don't see the diver come up, panic, and then suddenly lost consciousness, then regain consciousness. You say, oh, it's okay, fine, let's just continue our diving. No, we really have to watch him closely, give him oxygen. So the treatment is actually similar. It's very hard in the field, and even clinically, patient come to us to differentiate between cerebral arterial gas embolism and decompression sickness. But it doesn't matter because both require the same treatment: initial treatment of recoil and definitive treatment of oxygen recompression therapy. This is the chamber in Hospital Angkatan Tentera Tuanku Mizan, Setapak, KL. 2 compartment. We have a 2 men here and 8 men there. You can see inside how it looks like. 8 people can sit inside. We can remove the seat and put a lying down patient intubated. This is an old picture, intubated diver in a Lumut chamber. So that's pulmonary barrel trauma of cerebral arterial gas embolism. Pretty rare, thankfully. I maybe get less than 2 or 3 cases per year. It's pretty uncommon nowadays. People are pretty well trained doing the diving. They don't do crazy things. Yeah. The other more common one, barrel trauma, will be middle ear barrel trauma. This is the most common type of barrel trauma, and every diver somehow during their career or their diving life, they will experience this, also known as ear squeeze. And this is caused by failure to equalize the middle ear pressure with the environmental pressure. Yeah. So either block or dysfunctional tube, or most commonly is improper technique. So what happens is that Boyle's law again, increase in pressure, it will press against the eustachian tube as well, your eardrum, so you can get pain. And if you don't clear it by doing Valsalva or swallowing or other methods, then your eustachian tube becomes clamped shut, and all the fluid and blood from the middle ear will engorge into the middle ear space. The eardrum will bulge in, and you can get pain, of course, also rupture eardrum. So some of the risk factors includes either you have some pathology, URTI, polyps, yeah, certain drugs, but most important or the most common cause is actually poor equalization technique. And pain during the dives, sometimes it can be life-threatening, especially in diver who are not well trained. Suddenly there is a rupture in your eardrum, cold water go in, causing caloric stimulation and can cause vertigo, vomiting. And vomiting underwater is no joke. You can panic. You don't know how to breathe through your ventilator with a vomit. You will panic and shoot up to the surface, and then you end up either drowning or cerebral arterial gas embolism. So these are some of the pictures of middle ear barotrauma, grade 1, grade 2, grade 3, up to grade 5, where there is a rupture.
Oh my God.
And commonly related is sinus barotrauma, also pretty common. When again, Boyle's law, blockage of your sinuses. And when you compress, you go diving, you get headache. And sometimes if there is fluid and blood mucus inside, when you ascend, blood will come out through your nose. It looks really, really scary, but actually sinus barotrauma is pretty common, mild. All you have to do is stop diving, wait for a week or so, you will resolve. Yeah. So headache, epistaxis, pain.
When I started diving, I used to get that a lot.
Yeah, yeah. So sometimes maybe all your polyps is now ruptured. So you
Oh
don't get.
no, I think it's too fast because that time I couldn't get my buoyancy right? So I shoot
up
up.
and down, up and down. Yeah.
Yeah.
So because of Boyle's law, your sinuses are being, expand and then contract, expand, contract, causing the blood to engorge and come out.
Okay.
And finally, another one I wanted to share is face mask barotrauma. Those who are not divers will be wondering why you have this special dive mask which cover the nose. Why can't I use goggles? The reason being you want the nose to be inside the mask so that you can actually equalize your mask. Otherwise, you end up like this. Boyle's law, pressure increases. It's going to push against your goggles, and your face will get pulled into the goggles, and you get this funny face. Everybody will be laughing you at the boat. You'll be like that for the next 3-4 days, harmless, but look really funny. Okay, so that's the reason you have a nose to be covered inside your snorkel in your face mask for diving. That's barotrauma. There are many other barotrauma, GI barotrauma, dental barotrauma, soot barotrauma, which won't have time to discuss. But just quickly show you some of the other diving-related illnesses or diseases. Nitrogen narcosis, I mentioned. When you go deeper, 30, 40 meters, you cannot use air to dive anymore because of the nitrogen. It becomes narcotic. So you do funny things like removing your regulator, start taking out all of your gear, so that's nitrogen narcosis. So if you want to go deeper than 30, 40 meters, you need to use other inert gas. You have to ganti or change nitrogen to hydrogen or helium, other gas. And we also learn about oxygen toxicity, other gas toxicity, carbon dioxide, carbon monoxide, immersion, pulmonary edema, and other things as well, which is pretty interesting, very kind of topics in diving medicine. A little bit on fitness to dive or medical examination of divers. One of the other things that we do as diving medicine doctors, besides treating divers, going diving, we also see whether other divers are fit to dive as well. There is no saliva test to say that you're fit or not. Neither is there anything like, okay, no disease means you can dive. It's more complicated than that. And it depends whether you are a recreational diver, commercial diver, or military diver. For example, this guy come to you, I have been amputated, can I dive? Or nowadays, super obese, say, I want to dive. Or children, can they dive? So all these are questions that you need to answer. And to answer that, you need to have knowledge in terms of what is diving, types of diving, what are the equipment used, the gas used, the environment, and what are the regulatory requirements or standards. And then only you can do a proper examination, advise them what kind of diving they can do. Of course, it's different in the military where they must be fully fit. In fact, for the military, it's the easiest diving medical because as long as anything abnormal, we just disqualify them. Recreational is the hardest because there are dive club in overseas, asthmatic dive club. In Malaysia, we have a dive club that brings OKU out to dive. So, it's possible. And whether it's initial diving medical and then some like commercial and military, we do it annually, and it's compulsory for them. Others like recreational is voluntary. So basically that is diving medicine in a nutshell. And if you allow me just a couple of minutes, I would like to share clinical hyperbaric, which is actually more of my passion. Just 2 or 3 slides. Clinical hyperbaric medicine is actually using oxygen, 100% oxygen under pressure in a hyperbaric chamber to treat or various or to assist in helping treating other various conditions. Yeah. So as a hyperbaric physician, we consider oxygen as a drug. And as with all drugs, there is a dose and a prescription. So for example, the dose could be 100% oxygen at 2.8 atmosphere, 2.4 atmosphere, whatever your hyperbaric doctor want to prescribe. And it could be which table 14 meters, 18, 60, 30 table, various kinds of prescription, and can be daily, twice daily, OD, BD, yeah, same like our Panadol that you give, and whether it's 10 days, 20 days, 30 days, so on and so forth, depending on the indications. So how does it actually work? Again, Boyle's law, bubble reduction, it reverses hypoxia and restore normoxia because you're giving a lot of oxygen and achieving hyperoxia. And all these high oxygen have various effects. Probably a lecture for another time. Clinical hyperbaric is usually a 2 weeks course as well. You have stem cell simulation, increase in ROS activities via nitric oxide and alleviation of inflammation and so on and so forth. Pretty complex, not all I understand fully as well. But through these 3 main things of reducing the bubble size or hydrostatic compression, restoring or treating hypoxia or high oxygen concentration, you can use it for various indications. And in Malaysia, we pretty much follow the indication by UHMS, 15 indication that is approved and paid by the insurance over there. Things like crush injury, compartment syndrome, problem wounds, compromised graft. And I really love to treat radiation injury, delayed radiation injuries, things like radiation cystitis, osteoradionecrosis, whereby patient comes in with problem, ulcer or bleeding years after radiation. And hyperbaric oxygen therapy is one of the really important treatment to reverse all the effects of radiation. Yeah, other things like burns, idiopathic sudden sensory neuralgia, and the latest one just added this year is very early stage aseptic osteonecrosis or avascular necrosis. So in summary, diving medicine is a very specialized field of medicine encompassing a wide range of medicine from physics, physiology, preventive medicine, occupational medicine, emergency medicine, critical care. Really interesting field, however, or very unfortunately, not widely taught in our regular medical curriculum. And through our society, we are trying to do that. Recently, 2 months ago, we held our introductory seminar in diving medicine in KL, and it was really, really overwhelming attendance. We limited 30, and there was something like 10, 15 more on the waiting list. Hyperbaric medicine, again, not widely taught. We need more awareness because I think we are behind other countries in using HPOT as a definitive or adjunctive treatment in various conditions. I've chatted with people from Indonesia, Thailand, Australia, UK. They are in their insurance scheme, treating for problem wounds, diabetic foot ulcers, radiation-related injury. So hopefully in the future, there'll be more awareness, and this is just a small introduction to both diving and hyperbaric medicine. Thank you so much, Beating Heart. Thank you so much, Betty, for inviting me to give this small talk and sharing with everybody.
Yeah, okay, go back to the slide for indication for hyperbaric chambers. Can you hear me now?
Yes.
Okay, How come there's no for aging? Does it work for aging? I want to try.
In a short answer, no, it doesn't.
Okay,
Yeah, it's not in the
I was
indication. I
hopeful.
wish it was, then I'll be very rich. There was a study by the Israeli group that found elongation in telomere after extensions of hyperbaric, but I don't know whether that's clinically translate to prolonged life or not.
Okay. So Ken asked, how does PFO contribute towards a higher propensity to get DCS? Okay, it doesn't, right? It only increases the risk of that particular skin problem, right?
No. It does. It does increases
Yes?
of spinal DCS paralyzed, inner ear DCS. You get hearing loss and imbalance. So when these two condition presents, we would be looking for PFO.
I
The
see.
skin one is the cutis marmorata, specific skin band, not the other types of skin band. That is what you call a sign of a severe bubble overload or PFO. So why you get a higher propensity is only those with a big PFO, only those with what we call undeserved bands, undeserved DCS. So if you dive 1,000 dive, 2,000 dive, you never have any problem. Suddenly you get DCS. I won't be looking for PFO because we know that in the general population, 20% of people have PFO. So it should be similar in the diving, in the diver. So thousands and thousands of divers going diving every day, we don't get thousands and thousands of DCS. Very rare. So PFO per se does not increase your risk unless it's a very big PFO.
Okay, we go on, yeah? Ken again asks, what is the procedure if one faces an unlikely case of DCS during decompression stop at high PO? That's such as 6 meter. Stop with pure oxygen. They then rush to the surface and have a pause.
Very technical. This Dr. Ken Chang is asking
Well,
if
Ken is not a
somebody
doctor. Ken is a diver.
whether is it likely or unlikely to get DCF is somebody using high partial pressure oxygen. So which means probably using a rebreather and is using 100% oxygen or something, and then rush to the surface and you get DCS or cerebral arterial gas embolism, and ask whether with such a long exposure oxygen, whether we still administer oxygen. Yes, we still need to give oxygen. Whatever is it, oxygen. So in that case of using a rebreather, 100% oxygen, there is no nitrogen. What you get is oxygen bubbles. Yes, probably you may have a less severe one, or you might have a better outcome. We don't know. But a rupture in the lung, one bubble, any bubble, whether it's oxygen or nitrogen bubble, can still cause blockage and symptoms of cerebral arterial gas embolism. So you still need to give oxygen. You still need to give recompression therapy.
Okay, Dr. Victor from Doquity asks, kindly your explanation of free dive athlete. How do our body train to endure that? Do they must decompress once they reach the surface? And how is the efficacy of portable hyperbaric?
All right, there's 3 questions there. So for free diving, they actually learn not only to hyperventilate, how to get rid of their carbon dioxide so that they reduces or they change the set point for the need to breathe in. They also train psychologically to overcome that hunger for breathing. And they also do special technique called lung stacking. I don't know how to do it, but they use their glottis and their tongue to force air inside their lung, and their lung is actually bigger than their total lung capacity. So that's how they train for it. And I think it's also a lot of genetics. Certain people just somehow can tahan longer, can have bigger lung volume, so that they can last 11 minutes without breathing. Normal human like us can't. Okay, so the other question is, must they decompress once they reach the surface? So because this is non-compressed air breathing, they are only taking a single breath from the surface, 1 atmosphere. No matter what depth they go to, they come back up to the surface, they are back to 1 atmosphere. So there is no decompression stress. so they do not need to decompress. Okay. So only if they take one breath, go underwater, and then they got their kawan underwater, give them a scuba tank, they take another breath from the scuba tank, then yes, you have breathed compressed gas, then you're at risk of decompression sickness. You need to decompress when you come out.
Okay, we have one question from Facebook.
Yep.
Does Terence Go ask, does it help a scuba instructor to go for chamber for maintenance yearly?
Sorry, I lost you there.
Okay, sorry. So he is asking, does it help if a scuba instructor goes to the chamber for maintenance yearly?
No, this is something that we seems to be permeating in the scuba instructor, dive master community, where they think that the myth that, okay, I've been doing so many dive, I'm taking students diving every day up and down. Every few weeks, I should go to the chamber and get oxygen to hyperbaric oxygen to sort of get rid of the bubbles. But no, if you know decompression theory and how bubbles form and how Henry's law, how we get bubbles in the nitrogen and how we remove nitrogen, people have been diving daily, the commercial divers, much more than the diver instructors. You do not need to do this. Okay. So we used to get groups of divers coming to us and asking for oxygen soak. And I told them it's not necessary, yet they insist. So the only way that I can discourage them is that each and every one, I take a 30-40 minutes thorough history, physical examination, make sure they're not decompression sickness. And if I find anything at all, I'll say, okay, look, you cannot be a dive instructor anymore because you are likely having decompression sickness. I don't think you should be diving. Then they will never come back again. You don't need to. All right, you don't need to. If you really want to be safe as a diving instructor, even better, just buy an oxygen tank. After every dive, breathe oxygen. That will be called surface decompression with oxygen, and commercial divers do that. They go inside the chamber immediately. So not coming for treatment. Treatment is different.
Okay. So Dr. York from Docquity asked, I have a friend who did decompression dive and complicated his decompression stop accordingly. But when he surfaced, his right ear has loss of hearing immediately and showed that there's profound sensory neural hearing loss. He did not proceed to hyperbaric chamber.
Without knowing in detail the history, just spot diagnosis, possibly inner ear decompression, possibly. Pretty rare. So if the diver were to come to me, I would like to know what gas was he using, whether it was a mixed gas, helium kind of gas, or so on, and whether there is any associated imbalance, nystagmus, what do you call that, vertigo. All those will point more towards inner ear decompression. Otherwise, we have to look into the ear, see whether is it inner ear barotrauma. But it's been so long, the risk of it being healed would be pretty low. But no harm seeing a diving doctor just to go through properly the history and examination and see what is it.
Okay, see a diving doctor. When you say that, but you don't even have a clinic, do you? You don't have, you work as an anesthetist.
Yeah, well, there are not many around. So usually we either get patient coming to us at our military hospital. We are open to both civilian and even foreigners as well, because there's no other place to go. But there are other diving doctors around. In our recent ASM in Koh Samui AHDMA meeting, we meet people from all over the country. We have doctors in KK, Miri, JB, KL, quite a number. They are around. The commercial divers know who they are. They go there for their annual medicals. So certainly not many, but they are around.
Can we train our GPs to be diving doctors?
I think it's possible. We can
do up a diving course.
What we would love to do with our society to organize diving medicine course, usually a 1 week, 5 days course. Yeah, that's something, a good suggestion for us to look into.
Okay, Beating Hearts will do with you. The diving course. Okay. So Dr. Amirul asks, how do I know or check when the next course regarding diving medicine, especially level 1
Okay.
DMC?
So at the moment, level 1, when they talk about level 1 diving course, this is what we call EDTC, European Diving Technical Committee. This is commercial diving training, diving medicine training. Level 1 is examination of divers. Level 2 is treatment of divers. So level 1 course, unfortunately, there is only one place in our ASEAN region, which is in Singapore. The next course is in October. AHDMA is planning to organize the EDTC level 1 course, hopefully next year. We are getting the approvals and so on in place. So please check our website, keep an eye on it. Yeah.
Okay, then work with Beating Hearts. I can put it in my website also.
Okay.
Okay. So that's to answer your question. Okay, Dr. Abdul asks, hyperbaric oxygen in wound treatment. Okay,
Yes.
his question is just like that. So
Yes, it is one of our main treatment indication. 50 to 60% of our patient in KL chamber, Lumut chamber is diabetic foot ulcers and other problem wounds. So yes, certainly, it will be a whole topic by itself. Hyperbaric oxygen therapy as an adjunctive to wound therapy.
okay, Chua Zhenzi asked, and I think it's a very important question because it's a career advancement. So he or he asked, how do he or she becomes a military doctor? And he's from KKM at the moment.
Okay, good question. There are a few ways. One, you could be joining immediately before your housemanship. You apply to the Armed Forces, ATM. And if you are a JPA scholar, everything you can convert. Or if you're not, you're a pharma scholar, then you can just apply and join. There are, of course, some requirements like certain health fitness level. Yeah. Otherwise, some take scholarship from the military before during their medical school. If you're already in KKM, used to be there is a pathway of secondment, especially during the communist time and even up to the 1980s, 1990s, where there is shortage of military doctors. They will ask from KKM and they second them over for short commission for 3 years or so on. Recently, JPA have approved the about 200 over new posts for doctors, military doctors. So you can try and ask, but there is an age limit. I can't remember what's the age limit, 35 or 39 or something. We don't want all these to be, so just.
Oh, I'm so sad.
So yeah.
A brigadier
So yeah, if you're a
general.
young houseman, a young MO, you can still apply and switch over to the ATM.
So this brigadier general post that you have stays with, I mean, the name title stays with you forever, right? Even you retire.
Yeah, I during my retirement process, I will apply to the Yang di-Pertuan Agong for perkenan to use the rank after I retire.
Wow, sounds so good lah. Professor also not so nice lah. Brigadier general. I wish I joined the military earlier. Okay, I think we will stop here. It's already 10 o'clock and it was an amazing lecture. You are very good. Very, very good.
Thank you so much.
Yeah, I hope to bring you back and then maybe we can work on the course. Seems like, especially I think in some areas, will be very useful, like our Sabah area where
Yes.
the GPs can be
They see divers a lot. This has been a wonderful session of sharing. I always love to share with people diving in hyperbaric medicine. Is a very interesting field. I love it. Being an anesthetist, sometimes it gets a bit boring. 99% of the time, nothing happens. And with diving in hyperbaric medicine, you encompass everything from public health to critical care to preventive, everything. Physics, physiology, and of course, I love diving and I love sharing with people. I just hope more and more people will know about this, and especially in clinical hyperbaric, and people will start treating. There are new chambers coming up in Terengganu, in the Kelantan, so hopefully that will jumpstart KKM.
how much is one chamber?
You mean to buy it?
Yes.
It depends on the size. Like the one you saw, the monoplace chamber ranges between different brands. Ranges between 100,000 USD to 300,000 USD for one monoplace chamber. For the bigger multi-place chamber, where you have 2 or 3 compartments, can treat many patients, ranges from 1 to million US up to 20 million US. Yeah.
Can the insurance, like say for the treatment of wound, can we claim from the insurance?
Haven't been tested. I've been in the public service all this while. When I go to the private, I will try to find out. But as far as I know, it's not inside the schedule. So we will probably need to find a way how to get it in, because I mean Australia, Singapore, UK, US, insurance pay for it. Don't know why it's not in Malaysia.
Good. So I hope to bring you back for some more talks, of course. Next year, because I think this year also full up already.
No
and
problem.
then of course watch out for our courses. Beating Hearts is also looking into doing cardiac emergency courses, basic life support courses, and of course hopefully eventually courses that maybe will elevate and help the GPs to do like palliative care and also diving. One step at a time. Okay,
Yes.
thank you very much. Hey,
Thank you so
very
much for inviting me.
Andrew.
Thank you everybody for your time out on
It was
a
so
late
great.
evening.
Yeah, I love it. I love it. Okay, bye guys. See
Thank
you
you.
next week.
Bye.
We're doing infertility, if I'm not mistaken. Okay, bye-bye. Hey, thanks, Andrew. I see you at work.
Thank you.
Okay, bye-bye.